Remind ourselves that these drugs can cause dehydration. And when we cause dehydration, we're going to actually decrease renal blood flow. And that's going to decrease efficacy. And there's other drugs that might do that as well. Now, it may be because of this, but it may be because of other reasons that these drugs will actually enhance the nephrotoxicity of other drugs. And so as a general rule of thumb, if you are administering a drug that causes nephrotoxicity, you want to not use a diuretic, just because it will enhance it. And there are lots of examples. Non-steroidals are a good example. Aminoglycosides, which you'll get next year, those are nephrotoxic drugs. And then notice I have ACE inhibitors here. We're going to talk about ACE inhibitors today, and one of the things we're going to find out is that ACE inhibitors can actually cause an acute renal decompensation. And so we'll need to be a little bit careful in some patients, and notice I said some patients, at-risk patients, and we'll define those when we get there. But that's why I've got the question mark there, because not all patients receiving ACE inhibitors are at risk. So those are some examples of negative interactions. The positive interactions are the synergistic effects that we're talking about, the diuretic combinations. And we'll talk about those as we go through the individual drugs. But notice what's here as well? ACE inhibitors again. We will actually use ACE inhibitors in combination with diuretics because it will enhance preload and afterload reduction. But we're going to have to do it carefully. And so when we get to ACE inhibitors, we'll talk about how we can use ACE inhibitors to slow the progression of renal disease. But we'll also have to be careful with ACE inhibitors because they can cause acute renal decompensation. So hold on to that question until we get there and see if we can make sense out of that. Okay, so those are the principles, some things that we have to be thinking about as we use diuretics, and especially natriuretics. So the first class of drugs we're going to talk about are the osmotic diuretics, which really we don't use for their diuresis. And our model drug is going to be mannitol. And if you look at mannitol, it's got all these OHs on it. Well, whenever you've got OHs, that's going to have some kind of osmotic draw. Now, the most common osmotic diuretic is ethanol, our game day diuretic. And if you've taken this, who hasn't, then you know that. You spend more time in the bathroom on game day than you probably want to because of this diuretic effect. There are others, glucose. One of the reasons that the diabetic animal urinates is because the glucose is an osmotic diuretic. They urinate like crazy. So, if we're thinking about an osmotic diuretic, something that we want to increase urine production, then this has to be something that is freely filtered by the glomerulus. We want it to be something that's neither resorbed nor metabolized, and we want it to be something that is pharmacologically inert. We don't want it to be metabolized, we don't want it to cause other effects. Now that's if we're going to use it as a diuretic, but these characteristics are also true if we're going to use it to decrease intracellular edema. We want it to be freely filtered, we don't want it to be metabolized, we want that molecule at the cell, we want it to be pharmacologically inert, we want it to just sit there and draw water out. So let's talk about how that happens. So, I've drawn this little diagram to try and explain what's going on. Yes, ma'am?
When you say pharmacologically inert,
we don't want it to do other things. So pharmacologically inert, we don't want it to cause other effects. Okay?
But it would still be treated as a drug in the body, right? It would still go through pharmacokinetics, or?
So pharmacologically inert means it doesn't interface with receptors and cause a response.
Okay, but then it would still undergo metabolism and excretion?
Doesn't undergo metabolism at all. That's what we don't want it to do, because we want it to stay as an intact molecule. Metabolism is changing the molecule.
So how do you get rid of it? Like if you were to solve the issue that you're...
How do we get rid of any drug that we don't metabolize? In fact, how do we get rid of drugs that we do metabolize? Urine. Yeah. We renally excrete it.
Okay.
And that's exactly what we want this diuretic, we want it to do. We want it to get, if we want a drug to increase urine because of osmotic draw, we want it to not be changed. We want it to get down there and do its job. Now, having said all that, remember, we're not using this drug to increase urine. And this diagram is intended to tell you why. So, what we are going to use this drug to do is surround the cell and cause an osmotic draw. But let me share with you why these aren't good diuretics. So here we have water in the tubular lumen. And normally what will happen is the kidney's going to reabsorb that. Well, if we put mannitol down there, then this mannitol, if we get enough molecules in the urine, now we're in the urine, if we get enough molecules in the urine, what it's going to do is it's going to make it harder for the kidneys to pull it back up. Just because there's the osmotic draw that those molecules have on the water. And so what will happen is water will stay in the urine. But then what's going to happen as more and more water stays in the urine because of these molecules, the urine's going to get dilute. And once the urine is dilute, then the body just starts picking it back up again because that osmotic draw has declined. So it's a self-fulfilling prophecy. The drug will cause urinary retention and will cause more water to be formed until the molecules get diluted enough when their osmotic draw is no longer effective. Is that making sense? Okay. So that's why they're not good diuretics. They're initially good, but pharmacologically for long-term management, they're not that good. So why do we use them then? Well, we're going to take advantage of their osmotic draw, not in the kidneys as much as in other sites. And remember, when a cell membrane is damaged, it is no longer able to maintain its permeability. And the outside of the cell is always hypotonic compared to the inside of the cell. Intracellular fluid is always hypertonic compared to outside. So if there's anything that changes the membrane permeability so that it can't protect itself, we're going to see fluid move into the cell. What happens when fluid moves into the cell? It swells and it runs the risk of dying. And what happens if fluid runs into the brain in this enclosed cavity? What's going to happen? Swelling, and the animal's going to herniate and the animal's going to die. So what we want to do is try and prevent that fluid from moving into the cell. So what we're going to do in this case is we're going to give mannitol IV. It's pharmacologically inert, it's going to stay intact, and mannitol is going to be able to get through the vascular endothelium. There's pores in there, and so it's going to be able to get through that vascular endothelium. And so what it will do is it will bathe, it will go into that interstitial fluid surrounding the cell, it will bathe that cell, and it will cause the outside of the cell to now become hypertonic compared to the inside of the cell. And when that happens, that means two things. A, fluid's not as likely to go into the cell, and B, it can actually draw whatever fluid has gone in there back out. So now I have more fluid in the interstitium surrounding that cell. And where's that extra fluid going to go?
Into the bloodstream.
It's going to go into the bloodstream, and then it's ultimately going to be urinated out. But between the time that I have this drug in the interstitium and it makes its way down to the urine, what's going to happen to my extracellular fluid? The volume of my extracellular fluid. It's going to increase, and that's the last thing I want to happen in an animal that has pulmonary edema. Is that making sense? So while this is good for treating intracellular edema by putting that osmotic drag on the outside of the cell, drawing that fluid outside of the cell, it's bad for increased hydrostatic pressure edema because it's going to increase that extracellular fluid volume. So we will not want to use this drug in patients that have pulmonary edema. Okay? Is that making sense? So we can use it to decrease intracellular edema, and one of the advantages of this drug, and it looks like a zebra down here, one of the advantages of this drug is it also seems to cause increased renal blood flow. And that's particularly good if I have acute renal nephropathy, because in that scenario where the kidneys have swollen, we're trying to get renal function back, we'll use mannitol to bathe those damaged renal tubular cells. Well, on top of that, the mannitol seems to increase renal blood flow for reasons we don't quite understand. So that makes this a good drug for acute nephropathies. Now, it turns out other things will respond. Intraocular pressure glaucoma. I mentioned earlier for acute glaucoma, you can actually use mannitol. But the primary place you're going to see mannitol used is probably increased cerebral edema. Okay. So, we've already talked about this. We've already talked about not using it for pulmonary edema. So let me see if you have any questions about mannitol. Okay. All right, so let's go to our second set of diuretics. And so that one would be this one. And with this set, we'll actually transition into natriuretics, okay? So these are drugs, natriuretics, these are drugs that influence sodium transport. These are the drugs that we're going to want to use in cases of increased hydrostatic pressure, pulmonary edema being the best example. Okay, so as you will recall, that the proximal tubule, as you will recall, there's a lot of sodium in retention in the proximal tubule, but as urine goes around this loop of Henle, one of the critical spots where sodium is picked back up is this ascending limb, because this picking up of sodium is what makes this countercurrent mechanism, which allows the reabsorption of water. So a lot of activities going on in this ascending loop of Henle. Most of this is occurring, at least in the ascending loop of Henle, via a energy-dependent mechanism. Other places, it's a sodium-potassium co-transport. So when we look at the ascending limb or the loop of Henle, there is this active transport process that takes sodium, potassium, and actually chloride will follow as well. And that's going to be the target of furosemide. So what will happen is furosemide is going to block this whole active transport process. And when it does, it's going to block the uptake of sodium, potassium, and chloride. They're all going to stay in the urine. Now, the other thing that's going to happen is it also turns out that furosemide blocks the uptake of calcium and magnesium for mechanisms we don't really understand. So that's not necessarily bad. In fact, it's good. There's really no negative impact of that. The positive impact is we can use this drug to treat hypercalcemia as well. And remember, hypercalcemia is life-threatening. The efficacy of this drug is so good that it's referred to as a high diuretic effect. You'll hear it referred to as a high ceiling effect. And because of that, furosemide is the most effective. It's also the one associated with the greatest risk. You can kill a patient if you don't pay attention to what you're doing with furosemide. Now, having said that, this is a drug where we've got to get it down to the kidney. So you've got to have sufficient renal blood flow for this drug to work. So for example, if you have an anuric patient, a patient in acute renal failure and the kidneys have shut down, well, furosemide's probably not going to work until you get renal blood flow down there. And so that's a problem. That's why mannitol might be the more appealing drug initially, because it will hopefully increase renal blood flow. Furosemide may increase it a little bit, but if your animal doesn't respond, then that means that probably not. Okay, so positive sequela, this is what I just said. We will see some increased renal blood flow for furosemide, but if your animal is totally anuric, then you're probably going to need to go to mannitol to help increase that renal blood flow. Now, here's one more positive sequela of furosemide. Another reason why I think veterinarians and people go to it right away. It actually increases the venous capacity. What does that mean when I say increased venous capacity? Yeah, our veins are going to dilate. They're going to increase how much they hold. Why is that a good thing in our patient with pulmonary edema? What's it decreasing? It's decreasing preload, okay? And that's potentially good. It's another mechanism whereby I can keep blood out of the lungs. I'm actually decreasing its delivery to the right ventricle, and therefore decreasing its delivery to the left ventricle and the lungs. Now that won't last long term. That's more of an acute sort of thing, but it's another reason that acute response to furosemide can be so good. And then the last thing down here is it may alter prostaglandin response. Prostaglandins are critically important to the kidney as it